If we are going to address the needs of vulnerable populations, we have to address the social determinants of health. And that's going to happen beyond the walls of the clinic. That's going to happen where people live. That's working with schools. That's working with faith-based organizations, with churches, with mosques, with synagogues. That is working with after-school programs. So the idea is that it really is listening to people on the ground to hear what their views of what their needs are and to help develop the solutions.
Today's PSA comes from Bobby Watts, Chief Executive Officer of the National Health Care for the Homeless Council, an organization that has been on the ground for nearly 4 decades, serving those suffering from homelessness. My name is Dr. James Hildreth, and you're listening to Public Service Announcement, a brand new podcast dedicated to making complicated healthcare topics easily digestible for all who listen. This season, we will focus on an array of topics like public health, health equity, data sciences, disease states, medical modernization, and more. In this episode, Bobby and I get down to the basics and discuss the social and political determinants of health and why addressing disparities among different groups may be the solution to fixing a lot of systemic issues in our society. We dive into the pronounced racial disparities in treatment of infectious diseases, partnerships between healthcare organizations, to engage with other sectors, to create healthier environments, and ways individuals and health organizations can engage with the community to empower and change social norms within healthcare. To learn more about this show, or to learn more about Meharry Medical College, visit www.mmc.edu. Bobby, welcome to the show. And can you introduce yourself and tell us what you do?
Thank you, Dr. Hildreth. I'm really honored to be here. I am the CEO of the National Health Care for the Homeless Council, and what the council does is provides training and technical assistance to the 300 federally qualified health centers that have a special emphasis and funding to serve people without homes, and about another 150 medical respite programs. So we are a national organization, and we are based here in Nashville, Tennessee.
Oh, that's wonderful. It sounds like really important work. So let's start with some basics. And can you tell us, what is health equity?
Yeah, there are several definitions, but the one I like the best is pretty simple. It is that health equity is the state in which everyone has a fair and just opportunity to reach their highest level of health. And because we are not all starting off at the same place, it's not a level playing field, that means we have to pay attention to those who are disadvantaged, whether because of income or historical reasons. So health equity means we are doing what we can to help everyone reach their maximum level of health.
And some people seem to confuse health equality with health equity. Can you explain the difference so that people understand that you don't do the same things for everyone?
Sure. I think we know this intuitively in our personal lives. If we had a child who had a disability, we would know we would not treat our children the same. Or if one child was really great at one thing and not another, maybe he needed extra tutoring in math, where one child excelled, we would make sure that we provided that, whereas the second child might excel in reading. So it's looking at where people are and giving them what they need to give them the best chance to succeed and to thrive.
One of the ways that we think about health equity is in the context of the social determinants of health. Can you explain to the audience what are the social determinants of health?
I'm glad to. The social determinants of health, and some people use the term social drivers of health because they feel determinants is too deterministic, no pun intended. But it really is saying that there are factors in people's environment, in society, that impact how one can achieve maximum health. So those are where people live, where they work, where they pray, where they play. And it's realized that a lot of these things are not healthcare that have a tremendous effect on one's health status.
One of the great demonstrations of this was during the pandemic, and I know that you were busy working in that situation as I was. In fact, we served on President Biden's Health Equity Task Force together. So can you, maybe in the context of the pandemic, give some examples of how underserved communities are disadvantaged by the social determinants of health?
Yes, and I think many people saw during the pandemic in ways they had not seen before how unequal our healthcare system is. From where I sit, especially looking at those who are unhoused, saw that they were at tremendous risk of contracting COVID and had much less access to care. But it was also for people, if you lived in congregate housing in an apartment building, you would be at more risk just by riding the elevators, where people who lived in private homes or could afford to stay home during the pandemic versus having to take public transportation. That gave various levels of risk that were determined not by their health status, but by their conditions of living. So those are great examples of how COVID impacted people differently based upon their social determinants of health.
And in that situation, individuals are afflicted with disease or unhealthy, and there are things beyond their control. So in totality, how does that affect the nation, the communities that we serve? Because there are these issues that some folks have no control over.
So what happens is that the whole nation is weakened. When we look at our system as a public health system instead of a private health system, we see that what affects one really does have a ripple effect. And during the pandemic, it did not matter how rich you were. If there was a shortage of physicians or a shortage of hospital beds in a community because there were people who needed those beds due to factors beyond their control, it affected everyone. So housing conditions. If someone has to live in an apartment building or in public housing and there is poor ventilation or it's crowded and you're more likely to get exposed, that's beyond an individual's control. So then society has to look at what can we do to proactively, in the moment, make people healthier, and long-term, what are the conditions that we can create as a society to keep people healthier?
And the population that you are focused on in some ways are the most disadvantaged of all because they don't have the stability in their lives in terms of housing and the social constructs that others of us enjoy. So why do you think this has become such an intractable problem in cities around the country, dealing with people who do not have a place to live?
We at the council view this mass homelessness crisis as a result of public policies. I like to say that our homelessness crisis is a result of failure at the federal level that's felt locally. The fact is that we don't have enough affordable housing, and we don't have enough subsidies to make housing affordable for those who need it. And this is directly a result of public policy. So when we think about the social determinants of health and also the political determinants of health, one of the results of our choices as a nation is that we have, at a given night, a minimum of 600,000 people living on the streets or in shelters in the richest country on earth. I'm old enough to remember when we did not have mass homelessness like we do now. So when we say it's intractable, I think we have to remember that we created this problem through our policies. And it really began in the early 1980s. In 1979, HUD's budget for making housing affordable was $77 billion in 1979 dollars. By 1982, the budget was $17 billion, so more than a three-quarters cut. And we have never really reached that level except for a few years in our pandemic response. But we have been underfunding affordable housing in our country to the tune, in today's dollars, of $75 billion every year for 40 years.
Wow. So what will it take to change that? How do we address this problem?
So there are a number of things. I like to say when it comes to homelessness, the solution is housing and services. And we know that works. We as a country have reduced the number of veterans experiencing chronic homelessness by over half in the last 10 years. And it was a combination of housing subsidies plus services to get them housed, to keep them housed, and to address their other needs, whether it was mental health issues or substance use disorder treatment. We found out, we know what works. We've proven that it works. We just have not done it at a scale commensurate with the problem.
Well, one of the things that seems to be associated with mass homelessness is the problem of behavioral health. And how do we address that? I mean, that seems like a significant problem as well.
It is for individuals experiencing homelessness, and we shouldn't forget that there are a number of families that are experiencing homelessness. And in those cases, behavioral health, whether that's substance use disorders or mental health, is not the predominant reason. It's mostly economics and having a poor safety net of support. But it is overrepresented among individuals experiencing homelessness. And fortunately, we know a lot of things that work. We know that supportive housing works. And supportive housing is permanent housing that has services built into it. So if someone has mental disorder, it's making sure that they get the services as part of the housing. And the same for substance use disorder treatment. So we know those work. Wherever we have permanent supportive housing, we see that it saves the system money because it's keeping people out of the hospital, out of jails because we have criminalized homelessness. We also have made tremendous advances with medicine. We have medication-assisted therapy treatment that we know works for opiate disorders, and that's the gold standard. And when that happens, we've seen many people turn their lives around. The key is to treat substance use disorder as a medical condition and not only a matter of the will. And we have seen that more and more when that is done, people are able to get the help they need.
You're CEO of the National Healthcare for the Homeless Council, and this is a tremendous organization that's had significant impact. So can you tell us what processes your organization has in place to help FQHCs with this specific population that you care for?
At the council, we've been doing a lot to help our community address the social determinants of health. One of the key things we do is really train our providers, and not just healthcare for the homeless programs, but we want to train the whole healthcare system, especially all FQHCs, in screening for the social determinants of health. That is one of the great weaknesses in our healthcare system. Though we know from a public health point of view, and even I think clinicians know from an individual provider point of view, that social determinants of health matter a lot, we as a rule, do not do a good job of screening our patients, asking them about, let's say, their housing status or what is their level of food insecurity. And I like to say, if you don't know that as a clinician, how can you know that your treatment plan is effective? And the simple answer is you can't. So we've done a lot to help our community learn how to ask the question, and then most importantly, to document it, and then to try to bring resources to bear on the relevant social determinants of health. As an FQHC, our community, they will treat someone even if they don't have the ability to pay. But when you need to refer the person to a specialist, if it's not documented in the electronic health record that this person has this condition, then the specialist will probably not ask, and then they will not be able to design an effective treatment plan.
I'd like to have you explain to the audience what an FQHC is, in fact, because many people might not be aware of the important role they play, especially in primary care.
Federally Qualified Health Centers, or FQHCs, were actually the very first program enacted by the Office of Economic Opportunity in the 1960s on the war on poverty. So it was created with 2 health centers, one in Boston and one in Mississippi, where they said, we want to address the health needs of this community, and we want to do it by listening to the community. So it is tremendously effective. There are now about 1,400 federally qualified health centers. And what they have in common is they have to meet rigorous standards of quality, and their quality has proven to be extremely high. And they also have to treat people without regard to their ability to pay. If they have insurance, you can bill the insurance. If they have Medicaid, you can bill Medicaid. But if they don't have insurance, then you need to see them anyway. So that has been tremendously effective throughout the country in addressing primary care. They have to provide a full range of primary care. Many of them have dental services. And for the healthcare for the homeless programs, which is a subset of the 1,400, they also have to do outreach in some kind of way, because it's recognized that just because you have a clinic doesn't mean people who are marginalized and have been shunned by the larger healthcare system will access it. So we have to have outreach in some kind of way, plus have to provide or have an extremely strong linkage for behavioral health care, that is, be able to treat people with substance use disorders and people with mental health disorders.
That's very good. Thank you. I'm not sure people realize just how important these organizations are in our communities. and certainly seems like a great option to make sure the homeless can be taken care of. Is there anything else you'd like the listeners to know about the homeless situation and what's happening with that population?
Yes, one of the things we have been doing recently is a lot of work at looking at homeless mortality. There aren't a lot of data, but the data that we do have from around the country shows that for every age group, the age-adjusted mortality for people experiencing homelessness is at least 3 to 4 times that of the housed population. And this has been consistent over the years. The average age of those who die on the streets is about 20 to 30 years younger than the general population. So that means we are losing 2 to 3 decades of life among this population. And that is a tremendous waste of human potential. And we see that homelessness kills. So if we want to see what are the impacts of social determinants of health, in many cases it's health and also life and death. And so we need to address the social determinants of health to have a healthy population.
Wow, that's shocking to hear that. I mean, that really, really is truly shocking. So in the work that the council does, what has been the greatest challenge for you all?
I think the greatest challenge that we've had is one that is very common in the healthcare system. There's been tremendous burnout as a result of responding to the COVID pandemic. A lot of moral injury that I think is especially acute in our community because we have gotten very good at treating the whole person. We've been doing that for 35 years of addressing the social determinants of health before it was even called that, of having integrated healthcare teams to provide multidisciplinary approaches to treating each individual. And it just got extra complicated at a time when there just was not enough housing, and it was so important just to keep people safe. Often we would have our clients go to shelters, but the shelters had to decompress and we're seeing fewer people because of the dangers of living in a congregate setting. So we're really proud of what our community did and also of our partnership with CDC and with HUD. And they approached us and took some of our guidance in issuing instructions and guidance for the country in how to keep shelters safe and how to address the healthcare needs of unsheltered people experiencing homelessness. So it's been a tremendous challenge of trying to keep our community strong and not to be overwhelmed by forces outside of their control.
I think that what you're describing is a great example of what can happen when organizations partner with each other to the benefit of people in our community. So how can other healthcare organizations partner with community leaders the way that you have done?
Well, I've been thinking about this for a long time, especially when running a health center in New York City for most of my career, or working at one and then running one. If we are going to address the needs of vulnerable populations, we have to address the social determinants of health. And that's going to happen beyond the walls of the clinic. That's going to happen where people live. That's working with schools. That's working with faith-based organizations, with churches, with mosques, with synagogues. That is working with after-school programs. Unfortunately, what I have seen is that healthcare organizations want to work with community partners, but they don't really treat the community partners as true partners, as equals. I've seen many times where health systems will not listen to the partners that they brought to the table. They said, we know you are the experts because you are providing food to the community. You're running a food pantry or a soup kitchen, and we want to partner with you. But they have their preconceived notions of what that means, and they're not willing to listen to their community partners. And what I saw a lot when I was working in New York City was when we were working on implementing value-based payment. Hospitals knew that they needed these partners, but they were not willing to share the resources so that they could be true partners and provide the data, et cetera. So I want to go back to the roots of the community healthcare movement, where I said it started in the 1960s, and it started by listening to the community. It's proven to be effective because that is what was done. And in fact, community health centers have to have more than half of their board members be patients of that health center. So the idea is that it really is listening to people on the ground to hear what their views of what their needs are and to help develop the solutions.
I think what you're describing is what I call cultural humility, where you recognize that people in the community often have great solutions to problems, they don't have capacity or resources. So I think you're exactly right. One of the things that I noticed in your resume or CV is that you have a certificate from a theological seminary. So what role does faith play for you in the work that you do?
Well, I want to start off by saying the council is a secular organization, and we have people from all faiths or no faiths working with us and in our community. But everyone also knows, for me personally, it is a driver. We view addressing homelessness in the richest country on earth as a moral issue, as a matter of social justice. And in fact, our mission statement begins and grounded in human rights and social justice. The mission of the National Healthcare for the Homeless Council is to build an equitable, high-quality healthcare system. So that is our goal. And I personally view that as a matter of, if we really believe what the Old Testament prophets say and what the New Testament teaches us, that we are all created equal, that God loves everyone, that we're all created in his image, that we are our brother's keeper, then we will have different public policies and different reactions on a personal level. So for me, that is what drives me, that belief in the intrinsic value of every human being made in God's image.
Well, I think that's one of the problems we are experiencing in our country right now, that not all lives are valued equally, even though we often have people stand up and say as much, but the evidence is very clear that that's certainly not the case. Thank you for sharing that. I'd like to have you close by giving us a call to action. So what do you think the most important thing for our listeners to know, and what would you like them to do having heard this conversation?
I think I would want everyone to realize that what affects the health of the public affects everyone, including them and their families. And that if we're really going to have an effective public health system, then we need to go back and look at the roots of why we have some communities and some individuals in poorer health due to conditions beyond their control, and do what we can to address it. I couldn't leave here without talking about the effect of our nation's history of racism and how that has affected and driven many of the health inequities that we face today. We see that in many of the social determinants of health, of the social drivers of health. And homelessness is just one example where African Americans and Native Americans are overrepresented by more than 3 times their share of the population of people who are among the most deprived of our nation's resources. And it's not an accident. It's a result of our history. These are the communities, these are the populations that had their labor stolen from them and were not able to benefit from the results of their labor, or had their land taken from them. So these conditions are the result of historical practices that, unfortunately, these practices continue to this day. So we need to have a healthy public if we're going to have a strong country. We can't be a strong country if we have significant segments of the population that are left behind through no fault of their own. And it's a matter of not only moral expediency, but also practicality, that we need to address the health of everyone. We need a strong public health system that is looking out for everyone. And when we do, everyone will benefit. Every individual in this country will benefit. Every family will benefit. Every community, every population group.
Well, thank you, Bobby. This has been a really great conversation. I certainly learned a lot, and I think our listeners did as well. So thank you so much for joining us today.
Thank you for having me. It's a true honor. Thank you.
Thanks for listening to Public Service Announcement. To follow along on the rest of our journey, visit www.mmc.edu. And please remember to follow, rate, and review this show wherever you get your podcasts.